So immune complex deposition, if it is in situ, that means there is deposition of immune complexes in situ in the glomerulus, in the basement membrane, then it is going to be producing some granular immunofluorescence. So whenever there is immune complex in situ formation, there is going to be granular deposition, and these granular deposits can be either subepithelial or subendothelial. In this case, it is subepithelial electron dense deposits. These are basically the localized antigen antibody interaction. These are discrete large immune complexes, and these immune complexes are formed locally by antibody that react with intrinsic tissue antigens with or with extrinsic antigens which is planted. So this antigen can be intrinsic or extrinsic, but the immune complex that is formed is forming in situ, and that is why we have this granular pattern. And whenever there is a deposition of immune complexes, there's going to be a thickening of the basement membrane, which we see in the light microscopy, and these are subepithelial electron dense deposit which we see by the electron microscopy. Now I would take this opportunity to tell you something very important, that you have to memorize these three findings very importantly, and you should not confuse between them, because this recently only I think this kind of question were asked. Just show you one example. If you talk about this minimal change, this is very important. What you can see is that in the light microscopy the finding is normal. There is no finding which you get in light microscopy. Light microscopy may minimal change disease may it is a normal, completely normal, and that's why it is minimal change disease, right? But in the electron microscopy you have effacement of food processes and you have no deposits. ठीक है, तो अगर आपको इलेक्ट्रॉन माइक्रोस्कोपी के फाइंडिंग्स दे आस्क, then you have to know that you do have findings in electron microscopy, and that finding is effacement of food processes. But again, there is no deposits. So there is one positive finding and one negative finding in electron microscopy. On the other hand, in light microscopy, it is completely normal, and there's no finding. And fluorescence microscopy, which means the immunofluorescence, is negative because you have no deposits. Since there is no deposit, the immunofluorescence finding is negative, and light microscopy is normal. But electron microscopy may you have one positive and one negative finding. So whenever you are asked in the question what is the finding of electron microscopy, please read the options very carefully, and also most importantly see what they're asking in the question. If they're asking light microscopy, then you will not have any of these features, you will just have a normal finding. So you have to be very careful of the question, what they're exactly asking you, and the options, because you have negative finding and positive finding both in this particular entity. So you have to be careful. So this chart may seem simple, but then there are some intriguing differences, and you have to understand this very carefully, and that comes from your concept which is being described in the earlier part of this chapter. So now we are done with this. So whenever there is in situ immune complex, is going to be granular deposit. And if you talk about the antibody now directed against the normal components of the GBM. So if this is the GBM and you have the antibody which is directed against the normal or the intrinsic components, then that will give rise to a linear deposit, or rather a linear kind of an immunofluorescence. There is no granular deposit. This is a linear kind of a deposit, and this happens in RPGN. So why? Because there is no immune complex formation here, and therefore you have this you just have the antibody, and therefore this is the linear immunofluorescence pattern which is seen in the case of RPGN. If you talk about the deposition of circulating immune complexes, now here there is no immune complex formation in situ. This is a circulating immune complex and is getting deposited in the glomerulus. Now why they are getting deposited in the glomerulus? Because there is some physicochemical and hemodynamic properties of these immune complexes which are getting deposited or localized in the glomeruli. This happens in case of SLE or IgA nephropathy, right? So this is basically the pathogenesis, and this is the basis of understanding a lot of important points. Now this is the classification. Nephritic syndrome, you have the PSGN, the RPGN. Nephrotic, you have the membranous minimal change disease. FSGS, membranoproliferative, HIV associated, and dense deposit disease. We'll talk about all these things in detail. What about the other glomerular diseases? The Alport syndrome, IgA nephropathy, or the Burgess disease. Mind you, this spelling is important. And we have the benign familial hematuria. Now I will first take you through the important points and give you a hang of the chapter before I go into the details of it. What about the PSGN, post-infectious glomerulonephritis? Obviously you know that these are the must know points or must remembering points. It is because of the antibody which is directed against the streptococcal pyogenic exotoxin B. Important MCQ point. So these basically I mentioned and I've highlighted all the important MCQ points here. There's immune complex deposition. Okay, and because as I mentioned that if this immune complex deposition, then what will happen, what kind of immunofluorescence you will get, granular, because immune complex deposition हो रहा है यहाँ पर, ठीक है. And there is complement activation. इम्यून कॉम्प्लेक्स में क्या हो रहा है, इम्यून कॉम्प्लेक्स फॉर्मेशन, हाउ डज इट हैपन, एंटीजन एंटीबॉडी रिएक्शन होता है, उसके साथ कॉम्प्लीमेंट भी ऐड हो जाता है, राइट. एंड दैट इज व्हाई you get this complement activation, and therefore in the serum the complement will decrease because the complements are getting used up and consumed in this process, and therefore the complement in the serum will decrease. So now this immunofluorescence is granular because it's immune complex deposition. And electron microscopy में you are going to get subepithelial humps. ठीक है, very important, this is subepithelial and not subendothelial. We have learned that in the membranous nephropathy also we had subepithelial electron dense deposits. Each of these words is important. Okay, in the MCQ they will be asked and you will again get confused if you don't remember each of these words. But यहाँ पर क्या है, there is no electron dense deposit, here there is humps. So this word is again classical of PSGN. ठीक है, this is subepithelial in position. Okay, so granular subepithelial humps similar to the findings like in case of membranous nephropathy. So just talking about the membranous nephropathy, these are the findings which you ultimately have to remember at the end of the day. Immunofluorescence may we have this subepithelial granular deposits. I've just talked about this. Light microscopy may you have diffuse thickening of the glomerular capillary wall, which means thickening of the basement membrane. Important. Electron microscopy may you have irregular electron dense deposit and effacement of the food processes, because this is a kind of a nephrotic syndrome. If I just take you back to this chart, you can see that membranous nephropathy is a nephrotic syndrome. It's a kind of a nephrotic presentation, and there's in situ complex deposition and diffuse capillary wall thickening. There's granular and diffuse kind of an immunofluorescence, and there's subepithelial deposits. These are basically electron dense deposit, and you also get effacement of food processes. So effacement of food processes is basically a finding of the electron microscopy only. ठीक है, तो जहाँ जहाँ पर आपको effacement of food processes का आंसर लिखना है, that will basically come under electron microscopy का findings में. Now another important point, this basement membrane material lay turn between these deposits appearing as irregular spikes. Okay, now these spikes are visible by the help of silver stain. Now mind you, the silver stain will color or stain the basement membrane, and these deposits which will appear as spikes, you know, these deposits are not colored. The deposits are not colored, but the basement membrane is colored. Okay, if I can just show you the image. So here you can see that basically the basement membrane is getting stained by the silver stain. So this is an important point. Again, you have to remember this for your MCQ. Now, if you talk about the glomerular proliferative, okay. Now, in glomerular proliferative, we have two kinds, type 1 and type 2. Type 2 is called as the dense deposit disease. Now, what exactly happens? Type 2 or dense deposit disease is a kind of a C3 glomerulopathy. There is activation of the complement system here. In the electron microscopy, you are going to find a finding which is permeation of the lamina densa of the GBM by a ribbon-like homogeneous extremely electron dense material. In the immunofluorescence, you're going to get C3 deposits which may be granular or linear in the basement membrane but not in the dense deposit. In type 1, you're going to get deposition of the immune complexes. The glomeruli have a lobular appearance due to proliferating mesangial cells and increase in the mesangial matrix. So basically here this membranous proliferative means there's going to be an increase in the mesangial matrix. You have a subendothelial electron dense deposit. Mind you, this is subendothelial, again a difference. Okay, so subendothelial electron dense deposit, there's duplication of the basement membrane giving rise to a tram track appearance. And in the IF, this is granular because you have the immune complex deposition. So जहाँ पर भी immune complex deposition होगा, it will be a granular kind of an immunofluorescence, and this is having a specific tram track appearance because of the duplication of the basement membrane. Okay, now Alport's syndrome में क्या हो रहा है? In the electron microscopy, you're going to find that the GBM shows irregular foci of thickening alternating with the attenuation or thinning and pronounced splitting or lamination of lamina densa, which is called as the basket weave appearance. So Alport syndrome में basket weave appearance and splitting of the lamina densa. These are the two important MCQs. Don't confuse them with this. This is going to be a tram track appearance in case of membranoproliferative glomerulonephritis. So now I will just come back to this So now coming to this, you can see that immune mechanisms are number one, it can be antibody mediated, in which you can have in situ complex deposition. Number two, circulating immune complex deposition, and cell mediated immune injury. We have gone through all of this already. Diseases caused by in situ formation, I've already mentioned about this, about the membranous nephropathy and all these points earlier. Antibodies directed against the normal components, I've already gone through this. I have mentioned that there's going to be a linear pattern of immunofluorescence, which mainly happens in case of RPGN. When there is an immune complex formation or deposition, after that, how does the glomeruli get injured? So basically, whatever the antigen may be, this antigen antibody complex formed or deposited in the glomeruli may elicit a local inflammatory reaction that produces injury, and this leads to inflammation, right? So there is leukocytic infiltration and proliferation of the mesangial and endothelial cells. So this electron dense deposit may be deposited at three positions. Number one, between the endothelial cells and the GBM, which is the subendothelial deposit, between the outer surface of GBM and porocyte, which is the subepithelial deposit, and also in the mesangium, right? So I'll just show you this particular diagram. You can see that this is basically the basement membrane. This part is basically the basement membrane. This is the outer is the epithelial side and inner is the endothelial side. So basically this is the basement membrane. If this is the basement membrane, then what is this deposits will be? These deposits will be subepithelial. And on the membrane, when we have deposits, is going to be membranous deposit. And on the inner side, when you will be having these deposits, is going to be subendothelial deposits. And if you have in the mesangium, it's going to be mesangial deposits. Okay, so this is basically the positions, and you must remember which comes under which. So just a brush up. Subepithelial humps are seen in acute glomerulonephritis. Membranous deposits are seen in membranous nephropathy and Hemans nephritis. Subendothelial is seen in lupus nephritis and membranoproliferative glomerulonephritis. Mesangial deposits are seen in case of IgA nephropathy. Highly cationic antigens will be deposited in a subepithelial location. Highly anionic macromolecules will be deposited in the subendothelial location. Okay, and the molecules having neutral charge or any kind of immune complex will be deposited in the mesangium. Okay, whatever immune complexes are deposited in the subendothelial portion and the mesangial regions, they will elicit an inflammatory response. But the immune complexes which are deposited in the subepithelial locations will have a non-inflammatory pathology. Now, if you just look at this diagram, these are basically the epithelial food processes. This is the effacement of the food processes, and this is the detachment of the food processes. This is just shown in the diagram. This is how it normally looks like. And this is when it is having a pathogenesis. Nephritic syndrome, very quickly, we have these features, which is hematuria, proteinuria, azotemia, hypertension. If you talk about the acute proliferative or PSGN, this is a cluster of disease which is characterized by diffuse proliferation of the glomerular cells associated with an influx of leukocytes typically caused by immune complexes. By immune complex containing streptococcal antigen and specific antibodies, and this is basically because of this nephritogenetic strains, which is 1241. Again, a very important question, and it is the M protein of these bacterial cells which is acting as the antigen. Again, a very important MCQ point. So this point I've already mentioned. We have this hump-like subendothelial deposits. I've already mentioned. We also have this subepithelial deposit. So please understand this point very carefully, that in case of PSGN, you have subendothelial and subepithelial deposits. Here you can see that in case of PSGN, you have this subendothelial deposits in the early stages, and you have the subepithelial humps primarily. So your answer should be basically subepithelial humps. If they're asking you, one answer is going to be subepithelial and not endothelial. But then in the early stages, if they're asking, and if you have similar kind of an option, then this subendothelial deposits are also present in the early stages rather, but usually the answer is going to be subepithelial humps. So why is this happening? Because initially what happens is there is in situ formation of immune complexes which gives rise to subendothelial deposits, and now this antigen antibody complexes, they migrate across the GBM and they reside on the subepithelial side. So basically they migrate across the GBM to come on the outer side and lie in the subepithelial side, but initially they were in the subendothelial position. Okay, so this is having a granular deposit. I've already mentioned this granular deposit is because of the subepithelial humps and not the endothelial. Okay, this is basically because of the subepithelial humps, because this is ultimately the characteristic feature of this kind of nephritis. So this is ultimately your question, so do not get confused. I've told you each of these points in detail. You have the diffuse and global type of involvement here. See that this is the normal glomeruli, and this is the basically PSGN, because you can see there is so much of glomerular hypercellularity seen because of the intracapillary leukocyte proliferation of the intrinsic glomerular cells. This image shows this electron dense subepithelial hump. These images can be directly given to you in the exam and ask questions about this. You have to identify that this is on the outer side, so this is the subepithelial hump which is seen in case of PSGN, and these are basically the granular deposits of the complement C3 protein. So this is how the granular immunofluorescence pattern looks like. Now coming to this crescentic or RPGN, it is basically associated with a severe glomerular injury. The most common histologic picture is formation of crescents. Okay. What are the different types of this RPGN? RPGN is basically equal to crescentic glomerulonephritis. Now, please understand that there is type 1, type 2 and type 3. Type 1 may there is anti-GBM antibody. So, this is going to be having a linear immunofluorescence pattern because it is anti-GBM antibody. Type 2 may you have the immune complex deposition, and in type 3 you have post-immune, there is no immune complex deposition. So, if I just go through this, number 1 is the anti-GBM antibody. As I mentioned, it will have linear because it is not having any kind of complex formation. So there is linear deposition of IgG and in many cases C3. This happens when these anti-GBM antibodies cross react with the pulmonary alveolar basement membranes to produce this clinical picture of pulmonary hemorrhage associated with this renal failure in case of Goodpasture syndrome. And in this case, basically the antigen involved is the alpha 3 chain of the collagen type 4. Very important in case of Goodpasture syndrome. There are two important points you have to remember. Number one is going to be your linear deposit, because you have this anti-GBM antibody. Okay, and number two is going to be this alpha 3 chain of collagen, alpha 3 chain of collagen 4. Very important. These kind of things will be asked to you in the exam. Okay, so this is basically the Goodpasture syndrome, which is coming under the type 1 of RPGN. Okay. Now type 2, as I mentioned, is because of the immune complex deposition, and here you may have IgA nephropathy, lupus nephritis, henoch-schwann purpura, and all these examples are there, and you know that there's going to be granular deposits of immunofluorescence. In case of post-immune, obviously there's going to be lack of detectable anti-GBM antibodies. There is no immune complex formation. Most of the patients of RPGN, they have a circulating anti-neutrophil cytoplasmic antibodies or ANCA. Okay, so some of them are ANCA positive. Sirf type 3 mein hi you are going to get this ANCA associated point. You can see that how this wrinkling of the glomerular basement membrane with focal disruption. You can see these areas are disrupted. This is the crescentic one, and this is the crescent which is formed. You can see this outer section. This part is the crescent. Okay, this part is the crescent. This entire part. This part is the crescent. And now you can see how this crescent is getting formed. Okay. Nephrotic syndrome, there is massive proteinuria more than 3.5 grams, hypoalbuminemia and generalized edema, and hyperlipidemia and hyperlipiduria. So now coming to membranous nephropathy, I've already spoken about this many times before. Autoantibody binding to PLA2R, a membrane protein that is present at the basal surface of the glomerular epithelial cell. These immunostains also reveal this PLA2R or THSD7A glomerular positivity in majority of the patients. So this is present, so please remember these two terms. And a characteristic feature is that they have a dramatic response to corticosteroids. Now coming to focal segmental glomerulosclerosis. Why is it focal? Because all the glomeruli are not affected. And why it is segmental? Because only a part or a portion of this affected glomeruli is involved. Characteristic degeneration and focal disruption of visceral epithelial cells with the effacement of the food processes resemble the diffuse epithelial change typical of minimal change disease and other porocytopathies. This epithelial damage is the ultrastructural hallmark of FSGS. So again, this point is important, that the epithelial damage is the ultrastructural hallmark of FSGS. The inherited forms of FSGS include this NPHS1, which maps the protein nephrin that gives rise to congenital nephrogenic syndrome of the Finnish type, producing a minimal change disease like glomerulopathy with extensive food process effacement. And the other one is the autosomal recessive FSGS from mutations in the NPHS2 gene, which codes the protein of podocin, and these mutations will result in steroid resistant nephrotic syndrome of the childhood onset. So please remember these points. Again, this may be asked somewhere or the other. Some mutations can also be there in TRPC6 in the adult onset FSGS. Now coming to IgA nephropathy or the Burgess disease, there is prominent IgA deposition, and the characteristic immunofluorescent picture is of mesangial deposition of the IgA. As you can see here that there is mesangial proliferation and matrix increase, characteristic deposition of IgA principally in the mesangial regions. You'll be having microscopic hematuria in this condition. Alport syndrome, this is basically because of the mutations affecting the type 4 collagen with that result in hematuria with progression to chronic renal failure accompanied by nerve deafness and various eye disorders including lens dislocation, posterior cataracts and corneal dystrophy. This is an X-linked trait. These males fully express the syndrome while females typically present with hematuria. So in Alport's syndrome, the most important point is the basket weave appearance. I've already mentioned this over here that the GBM will show irregular foci of thickening alternating with attenuation and pronounced splitting and lamination of the lamina densa, giving rise to basket weave appearance. So we are done with this PSGN nephritic syndrome, immune complex mediated. There's granular deposits because it's immune complex mediated. Then in the light microscopy, you are having a diffuse endocapillary proliferation, and electron may initially you have subendothelial, but actually it is the primary subepithelial hump. So you must remember these epithelial humps only. This is basically the answer that you're going to write in the exam. And coming to RPGN, again nephritic, 3 types: anti-GBM antibody in which you're going to have a linear deposit, immune complex mediated in which you're going to have granular deposit, and ANCA you have a no deposit. So basically in macroscopy also the features will vary among these 3 types. Membranous we have already done, minimal change we have already done. FSGS में this ultrastructural hallmark is the epithelial damage. There is focal and segmental sclerosis and hyalinosis. Effacement of food processes and epithelial denudation is present here. Now membranous proliferative type 1 may you have this nephritic or nephrotic presentation. There is subendothelial deposits. Dense deposit disease may also you have this dense deposit, and IgA may you have this mesangial or the paramesangial deposits, right? So and there's recurrent hematuria or proteinuria in case of IgA nephropathy. So these 2 are the MCQ points in this topic. So this is basically it. I hope you have understood why I took you through the entire topic, and please differentiate between all these 3 different findings when you are studying and when you are revising, and this is basically a last minute revision chart for the exams. I hope you enjoyed watching this video. If you learned something from me today and if you like my content and my effort, then please consider subscribing. I will meet you very soon in the next episode. Till then, take care, keep studying, and thank you for watching.